Hello, I'm Dr. Harold Zerlup. I'm a professor of medicine at Texas A&M University and Division Chief of Nephrology at Baylor University Medical Center in Dallas. Thank you for viewing this presentation on hyponatremia, clinical update on outpatient and long-term treatment. Hypotonic hyponatremia is usually divided based upon volume status of the patient, and it can be divided into three different categories. Hypervolemic hyponatremia, which we see in congestive heart failure, cirrhosis, and nephrotic syndrome. In this case, effective arteriolar blood volume is considered inadequate by the kidney and ADH is stimulated. Hypovolemic hyponatremia is caused by true volume depletion with appropriate ADH increase. And one of the largest categories is when the patient is euvolemic. And of that, SIADH is the most important that we see. This is the syndrome of inappropriate antidiuretic hormone secretion. And it's inappropriate because the patients are not volume depleted, and they are hypotonic, so they have no reason for ADH release, and therefore it's inappropriate. You can also see this with hypothyroidism, or people with poor osmolar intake, such as the person on a tea and toast diet, or in beer drinkers' podomania, the person who drinks excessive quantities of beer. You can also see it in patients with primary polydipsia, where they drink large quantities of water that overwhelm the kidney's ability to dilute. Euvolemic hyponatremia due to SIADH has a variety of causes. Anything in the central nervous system, whether it be infections, trauma, bleeds, hydrocephalus, can cause SIADH, as can a variety of cancers. Anything within the pulmonary system, such as infections, asthma, cystic fibrosis, pneumothorax, has been associated with SIADH. One of the largest categories is drugs, with the SSRIs and thiazides being the leading causes of SIADH in this category. But it can also be seen with antipsychotics, narcotics, certain chemo agents, and in first-generation sulfonylureas. Stress, such as which occurs with pain or vomiting, can cause ADH release, and we often see this in the post-surgical environment. Sarcoid and AIDS has also been associated with SIADH. Hyponatremia is the most common electrolyte disorder that we see. It's expensive and contributes to direct costs of up to $3.6 billion per year. Up to 28% of hospitalized patients in the U.S. may have hyponatremia, resulting in 3.2 to 6.1 million hospitalizations annually. In the community care setting, 7.2% of samples showed hyponatremia. Even small declines in serum sodium levels are associated with increased mortality, neurocognitive deficits, falls, especially in the elderly, increased hospital length of stay, reduced bone mineral density, increased risk of pathological fractures exclusive of falls, and increased cost of care. This slide shows a number of studies which looks at hyponatremia and mortality. And as you can see, depending upon the sodium cutoff, there is significant mortality. For instance, with a sodium of less than 120 in this study by Crook, mortality was 51%. When the sodium was less than 132 in this study, mortality was 30%. So you can see how it varies across the board depending upon the level of sodium. Neurocognitive deficits and falls are very common in patients with hyponatremia, even sodiums between 130 and 135. In this study, we looked at 122 patients who had falls. Hyponatremia was much more common in the patients who had the falls versus a matched cohort. Hyponatremia was associated with 21% prevalence of falls versus 5.3% in the normal natremic patients. Correction of hyponatremia improved attention deficit as measured by auditory and visual stimuli. In this study evaluating cognitive function in asymptomatic community dwellers living from the Hunter Community Study, cognitive function was higher in individuals with plasma sodiums of 135 versus those with sodiums of 130. After controlling for demographics and diuretic use, hyponatremia was associated with a 32% increase in fall risk. The treatment of hyponatremia is pretty straightforward, and there are numerous ways to go about treating it. Free water restriction can be used in both the inpatient and outpatient setting. We can use for acute and chronic hyponatremia. It's very inexpensive, and it can be effective if the patient can actually lower his water intake. But it is very difficult to adhere to, and depending upon the levels of ADH, water restriction may not even be possible. Hypertonic saline can be used in the inpatient setting only. It works well in life-threatening situations, but it cannot be used chronically, and there is a risk for overcorrection and osmotic demyelination. Demeclocycline, a tetracycline derivative, can be used in the inpatient and outpatient setting. It has not been approved by the FDA for this indication. It can help in chronic hyponatremia, but you're giving the patient unwanted antibiotic exposure. It is very expensive, and there are reports of nephrotoxicity. The Vaptans, both Conivaptan and Tolvaptan, must be started in the inpatient setting. They have limited outpatient use, at least for Tolvaptan, which is the only available form outpatient. And the FDA has said we can only use it for 30 days and then must stop. They're very effective, but can lead to overcorrection. There is a hepatotoxicity associated with it, and that's why there is that 30-day rule, and they are extremely expensive. Urea, which is generally recognized as safe by the FDA, can be used in both the inpatient and outpatient setting. It can be used acutely and chronically. It's effective. It allows liberalization of water intake, and it's very inexpensive. Raw urea has poor palatability, but ure-Na may or may not be covered by insurance, and this is the flavorized version. Sodium chloride tablets with or without loop diuretics can be used in both the inpatient and outpatient setting, relatively inexpensive. But you are causing sodium load to the patient. There are significant GI side effects. There's numerous pills that need to be taken, and it may not address water excess in SIADH. The latest guidelines for the treatment of hyponatremia recommend the use of urea over Vaptans and demeclocycline. Several major hyponatremia guidelines recommend urea use. It's safe, effective, well tolerated, but not palatable in the raw form. Urea has an aquaretic effect without associated electrolyte depletion. There's no concern of nephrotoxicity or hepatotoxicity. It can be used in the inpatient, outpatient, ambulatory, and critical care settings. Urea is rated as generally recognized as safe by the FDA. Urea works by inducing an osmotic diuresis and decreasing free water reabsorption. Urea also has a more specific effect in SIADH, diminishing the natriuresis in association with increased medullary urea content. This allows for increased excretion of free water, thus allowing serum sodium levels to increase. The European Renal Association, the European Society of Endocrinology, and the European Society of Intensive Care Medicine in 2014 released their guidelines for the treatment of SIADH. And what they said was, in moderate or profound hyponatremia, we suggest restricting fluid intake as first-line treatment. In moderate or profound hyponatremia, we suggest the following can be equal second-line treatments: increasing solute intake with 0.25 to 0.5 grams per kilogram per day of urea, or a combination of low-dose loop diuretics and oral sodium chloride. In moderate or profound hyponatremia, we recommend against lithium and demeclocycline. In moderate hyponatremia, we do not recommend vasopressin receptor antagonists. And in profound hyponatremia, we recommend against vasopressin receptor antagonists. Up to date says that urea is another way to increase urinary solute excretion and enhance water excretion in patients with SIADH. The administration of urea, usually at a dose of 30 grams per day, is effective. This regimen is well tolerated and has been used chronically in ambulatory patients. In this study, looking at urea for long-term treatment of SIADH, Decaux looked at 7 patients. Urea corrected the hyponatremia despite normal fluid intake, raising serum sodium to greater than 128 milliequivalents per liter. 5 patients taking 30 grams of urea a day drank 1 to 2 liters of fluid a day, and 2 patients taking 60 grams were able to drink up to 3 liters of fluid daily. There were no major side effects noted, even after treatment periods up to 270 days. In this other study looking at the long-term treatment of patients with SIADH, 13 patients were treated in a crossover study comparing the efficacy, tolerability, and safety of oral Vaptans versus oral urea for SIADH. Patients were treated with Vaptans for 1 year. Patients were then put on a treatment holiday for 8 days, and then they were treated with oral urea for 1 year. 13 patients were enrolled and 12 completed the 2-year study. In year 1, Vaptans-treated patients' sodium went from 125 to 135. Hyponatremia recurred in all 12 patients during the 8-day treatment holiday period. In year 2, oral urea treatment increased sodium from 125 back up to 135 milliequivalents per liter. The urea patient's dosing ranged from 15 grams a day to 30 grams a day. One patient dropped out of the study due to excessive thirst. One patient received urea developed hyponatremia without complications. In chronic moderate hyponatremia related to SIDH, urea is therefore effective and a safe treatment option for up to 1 year. Serum sodium levels after urea treatment were between 128 to 146 milliequivalents per liter. 2 patients drinking 2 to 3 liters of fluid per day were titrated up to 60 grams of urea per day. 5 patients on 30 grams of urea a day drank 1 to 2 liters of fluid per day. A clinical benefit was seen in all patients as symptoms of hyponatremia disappeared completely. All but 1 of 7 patients had increase in urine osmolality once the serum sodium concentration had returned to normal. The only reported side effect was headache in 1 patient, which disappeared when the dose was split, with half the dose taken in the morning and half in the evening. The risk of urea treatment and hyponatremia dehydration, if the patient does not drink enough fluid, is real. Patients who do not have free access to water should have their serum sodium levels measured frequently. In this study by Decaux, they looked at whether urine osmolality can help choose whether or not patients can be treated with water restriction. In this study, 29 patients who had SIADH were initially treated with water restriction to see if they could correct their sodium. If they could not, then 15 grams of urea were added, and if again they could not correct, 30 grams of urea were added. And as you can see, 9 patients were able to get along with mild water restriction, 8 patients needed 15 grams, and 12 patients 30 grams. If you look at this table, it shows you the pre-water restriction. These are the patients who could get water restriction alone. And in pre-water restriction, you can see that the urine osmolality was pretty low, mostly below 375. And with water restriction, they were able to get their urine osmolality and their serum sodium up. In the next group of patients, these are patients 10 through 17, the urine osmolality was a little bit higher, some of them into the 400 range. And these are the patients who needed the addition of 15 grams of urea to their regimen in order to correct their serum sodium. And in the following and final table from this study, it shows you the urine osmolality in those patients who needed 30 grams of urea in addition to water restriction. And as you can see, the urine osmolality prior to treatment was between 350 and 905 milliosms. So what they're showing you is that the higher the urine osmolality, the more likely they will not be able to correct with water restrictions alone. So this data indicates that around 30% of those patients could be treated with water restriction alone. All the water restricted patients presented with an initial urine osmolality lower than 400. In this population, if a patient did not normalize serum sodium with 3 to 4 days with water restriction alone, then 15 grams of urea was added to the water restriction. The urea dose was then increased to 30 grams if the serum sodium did not normalize with water restriction plus 15 grams of urea. Patients with polydipsia, excessive water intake, can also be treated with urea. In this study that appeared in the Journal of Clinical Psychology, 7 patients were treated for 4 to 18 months with urea, 0.3 to 0.9 grams per kilogram per day. Patients had a diagnosis of schizophrenia. The dose of urea was increased if the morning serum sodium was lower than 132. Urea treatment increased mean morning serum sodium from 127.5 to 136.5 by the second month of urea treatment. Urine mean osmolality increased from 86 milliosms to 159 milliosms per kilogram, probably without changes in water intake or urine volume excretion, as attested by the level of urinary creatinine excretion. 2 patients stopped urea after 1 year and subsequently developed symptomatic hyponatremia. To learn more about the management of hyponatremia, please review the European guidelines or the information on UpToDate. For more information about ure-Na, please see ure-Na.com.